Hello, everyone. Welcome to another Journal Club. We have a very important topic tonight to discuss, which is about the quality of life in patients with vestibular disorders. And to that end, we have two fantastic guests who have studied and written on this topic. And I will let each one introduce themselves, and we will start with Dr. Duval.
Hi, Elena. Thanks for the invitation. My name is Jorge Madrigal. I am an otolaryngologist with 17 years of experience treating vestibular patients. I am the current medical director of the Center for Dizziness and Vertigo here in Mexico City and in the city of Guadalajara, also in Mexico, and in Medellín in Colombia, with my partner here, Melissa Castillo. And we founded 2 years ago how do you say that in English?
It's like a social initiative.
Yes, called we started an entrepreneurship, it's okay to say, called Academia del Vertigo, and we aim to help all the health professionals out in Spanish in Latin America, providing them knowledge, trainings in the vestibular area. So thank you for the invitation.
Oh, that is fantastic. And it's so needed. So thank you for that super important work. And Dr. I want to say Bustamante, but that's because I always go by the most lasted names.
You know that in the US and in the rest of the world, it's like so many people just call me Dr. Bustamante, and it's an honor. My name is Melissa Castillo Bustamante. I'm an otolaryngologist from Medellín, Colombia. I'm also basically the Chief Operating Officer of La Academia del Vertigo. We are pretty happy because our initiative was highlighted by the Aspen Institute in the US. So we are really glad for that. And also I'm a medical director from the Dizziness and Balance Center here in Medellín. And with Jorge, we are, researchers. We do really love this topic. We love several topics, including postural perceptual persistent dizziness. So over the last 2 years, we have been dedicated just to understand what happens with the patients. So it's an honor to be here with you. And we hope that this information and this article that we prepared will be helpful for the healthcare providers that are with us in this journal club.
Absolutely. No, and congratulations on being featured for Aspen, and for both of you for being in the Barany Society, which is well-deserved and very exciting. And yes, I hope that I will get to see you there this year. But we will leave that for later. Right now, I really want to get into this article about the quality of life for people with vestibular disorders. So I have a few background slides because I like to make sure that all of our viewers are kind of on the same page. So we'll go through those efficiently. And we'll start with our favorite slide of all time, the vestibular system, which is our tiny little inner ear balance sensor. We have one on the left and one on the right. And that little sensor helps us know where we are in space and keeps our balance, and it helps our eyes work as a team with the vestibular system. And the brain integrates this information as well as information from our joints to help us know, again, where we are. This is very important to the brain. The brain wants to know, are we safe, right? Are we upright? Are we leaned over to the side? What's going on? So we need this vestibular system to work as well as possible. And it is unfortunately true that across the world, including in the United States, many people have vestibular issues or problems with their vestibular system. So in your article, you highlighted that at least 7 million Americans complain of vestibular disorders. And this can lead to, seeking quite a bit of care. In fact, more than 4 in 10 Americans will experience an episode of dizziness significant enough to send them to the doctor. Now, not every episode of dizziness means that they have a vestibular problem. There's lots of causes of dizziness, which is part of the challenge that many healthcare providers face as they try to sort out Is there one cause of dizziness, multiple causes of dizziness? I like to say sometimes there's many layers to the onion. So we're trying to sort out, what's going on and not miss anything important, but also, acknowledge that sometimes there are many aspects to why someone might feel dizzy. So some possible causes of vertigo include, but are not limited to, Meniere's disease, the BPPV or benign paroxysmal positional vertigo, vestibular migraine, and we're going to talk about each of these very briefly so everyone knows what these are, unilateral or bilateral vestibulopathy, and what some people call functional dizziness, other people call persistent postural perceptual dizziness. It's had a few names over the years, actually, but that is another possible cause of dizziness. And any of these can affect the quality of life for those who experience them. Folks who are trying to work, who are trying to take care of their families, who are trying to enjoy life, who want to be able to do their basic functions, getting dressed, walking their dog, you name it. So these are the things that I think about when I think about quality of life. Can we do what we want and need to do, not only to survive, but to thrive? So I promised I would define some of these conditions, and I'm going to do that here briefly before we get really into this wonderful article. Meniere's disease, which you mentioned, is a peripheral, meaning in the inner ear, not in the brain, vestibular disorder, which presents with fluctuating hearing symptoms, sometimes a fullness, a ringing in the ears, hearing loss, usually kind of develops over time. So these folks will have episodes of these symptoms that can last hours, sometimes minutes, it depends. And so there's a range of how long these symptoms last for a given episode, but they're recurrent and it's spontaneous. There doesn't seem to be a specific thing that we can see that would have set these off per se. And then of course vertigo as well, which we know this is one of the causes of dizziness. So another thing to consider is what's happening with Meniere's disease. I want to bring this up because I feel like this is one of the most challenging diagnoses for folks because the science is still working on understanding what's really going on. But the current theory seems to surround this buildup of extra fluid in the cochlea, which is our hearing structure that's a neighbor to the vestibular structure. And they share some pipes, as I like to say, some fluid flow. And so when this fluid builds up, it can create essentially damage to the structure temporarily. And then after that fluid resolves itself, then the structure tries to do some repair. Now, I would love for you, and I'm just going to call on you, Jorge, could you tell us if you want to add anything on that Meniere's diagnosis to your end, or kind of what you know about Meniere's disease?
Well, Meniere's disease is the oldest diagnosis we have in the vestibular world. He was described by Prosper Meniere for 1861, if I remember right. And of course, the importance of his work was mainly because he was the first doctor who says that a patient with vertigo, the cause may become, the origin will be the ear. I mean, Meniere didn't want it to explain a new disease. In fact, the main point was to show in France in 2 centuries ago, because in that time, it was thought that way, if you have vertigo, the problem was you have a lot of blood in your head, and all the blood treatments was making blood yourself or putting this animal that sucks your blood.
The leech, and yes.
What was a very nasty treatment. And it's interesting because that diagnosis, the oldest one, I think is one of the most problematic diagnoses right now. I mean, we don't have an exact answer about what's the etiology, what's the origin of the Meniere's disease. In fact, we are having a lot of problems trying to solve out, trying to compare the treatments available. For example, we know that almost every treatment described, it's about 60% of success, no matter what you make. Okay, and right now we know, or we think the origin of this is a lot of endolymph pressure in their inner ear, but we are not sure why this is increasing in pressure. In fact, right now we are thinking about 10 different diseases that compromise the syndrome of Meniere's disease. So I think right now, if we can find or we can detect exact what kind of Meniere disease we have in a patient, maybe we're going to offer them a better treatments.
I think that's an excellent point. So yes, science continues to press forward on identifying these
Yes.
root causes. That's what I always go back to. Yeah, what is the root cause? And unfortunately, it can be complicated. It's not always one simple root cause. It could be, kind of a combination of things. We're not sure. So we'll keep looking at that one for sure. Our next one we need to explain is BPPV. So this is where people will say there's something wrong with my crystals. These tiny, tiny little calcium carbonate crystals. They live in that small vestibular apparatus. They have a job to sense gravity, but sometimes they go in the wrong place. They go into one of the 3 canals or tubes that make up our vestibular system to sense different directions of movement. And so when those crystals are in that canal where they shouldn't be, and they shift because we change position, then that can move the fluid that fills that whole system. That can create movement of the sensor at the end of the tube called the cupula. That stimulates the vestibular nerve, gives a false sense of movement, usually to the person, such that they might feel like they're spinning, or they might feel like they're off balance, or they might just fall, frankly. So there's a lot of ways that these symptoms can present. People used to think it was only spinning, but that is not true. Would you like to add anything to that, Dr. Bustamante?
Well, the truth is that the BPPV is one of the most common diagnoses worldwide. So it lasts only seconds. It's basically attributed to positional changes. Basically, the posterior semicircular canal is the most affected with the canalolithasis. So we have this debris, or we have this autoconia that basically is moving to the semicircular canal. It can switch from one canal to another canal. It's not the most common. But I think it's Dr. Perez Fernandez who says that it's one of the most easiest diseases to treat, but it's also the most difficult to treat as well.
Yeah,
and
that is so true.
I think that's one of the most common sentences, which Jorge also uses in his presentations, and he cited also Dr. Perez Fernandez, and I always remember that, and it's totally true.
Totally true. Yes, indeed. Sometimes it's one and done, and other times, man, they can be stubborn. All right. So I tell my patients I'm always more stubborn than the crystals. Don't worry. All right. We're going to go with the vestibular migraine next. That condition is a variant of our common migraine, which most people think of as headache, a very particular kind of headache because it tends to have a genetic link. Even if we don't have a family member that we know that has it, there seems to be some relationship to our own genes and how they're not coding correctly. At any rate, it results in this complex neurologic condition that can cause episodic dizziness in the case of vestibular migraine, as well as imbalance that can last from seconds to days. It may or may not have headache with it, often has other features, like light sensitivity, sound sensitivity, and even motion sensitivity, things like that. So you know who I'm going to pass it off to, and we're just going to go back and forth. So you want to give us anything else, insight you want to give us to vestibular migraine?
Okay, first of all, it is important to know that migraine is not synonym of headache.
Yes.
I mean, headache is a symptom. Migraine, it's a diagnosis. It's the sickness. Okay, so you don't really need to have a headache to have vestibular migraine. Of course, it's part of the criteria, but it is not necessarily always to have the headache and the dizziness at the same time.
Right.
So first of all, not no, migraine is very, very, very common. It's about 14% of all the population in this planet will going to have at some time all the criteria for some kind of migraine. And vestibular migraine is only a part of this big group of migraines in talking about all the types. And this special type is like about 1% of all the people with migraine, puts the patient in a very sensitive way to deal with the motion and the lights and the stimuli coming from the outside. So it is very important that first, I think one of the three most common diagnoses, especially in women. And of course, it's some kind of tricky diagnosis because sometimes all the vestibular testings are normal, all the physical examination is normal, and it's not really correlation between how you see your patient feeling really, really sick and vomiting and have a vertigo, and you don't really find anything objective, a sign, a really clear nystagmus. In fact, seeing nystagmus is kind of rare, or you need to have the patient really, really, really bad to have just a small downbeating nystagmus. So it is very important, first for the patients to know this thing exists, and also for the healthcare professionals to be aware that also this is a very, very common, and of course it is not an exclusion diagnosis. It is not that if I don't know what's happening with my patient, surely he has a vestibular migraine. No, it is not that kind of diagnosis, but it is very important to detect the real people with migraine, because right now we have a lot of options of treatment for them.
Excellent. No, very good points. All right, that brings us to vestibulopathy or vestibular hypofunction. You'll hear many different terms. I consider it to be essentially, for lack of a better term, damage. Typically, the condition is due to damage, so to speak, or partial function or total lack of function in some cases to the vestibular nerve. But it could be just parts of the vestibular nerve. So sometimes we have sparing, so to speak. So maybe the horizontal canal is affected, but we still have sparing of the posterior canal, for example. And this can happen on one side, which we call unilateral, or the damage could occur on both sides, which is considered bilateral. And Dr. Melissa, what would you like to add?
Well, I think unilateral vestibulopathy is one of the most common diagnoses as well, but it's a little bit tricky. So we have to be pretty aware of how to evaluate and how to do the physical exam in the patients, because sometimes the differential diagnosis is a stroke. So it's pretty important because this is one of the, this is an acute clinical symptom, an acute basically emergency. So we have to be aware of what is happening. So actually today we have an emergency in the emergency room. One of the patients that basically we thought that it was a central vertigo, but instead of that we had a vestibular neuritis. Sometimes you have some specific tools, diagnostic tools that you can use, for example, the AV heat, but sometimes you don't have it. So we are pretty lucky to have that. And then we have the AV heat, we can make all the diagnosis, and it was pretty clear with the saccades, with all the findings. But if you don't have it, so you have to use the HINTS protocol that it's basically developed by one of my country fellows, Dr. Jorge Cata. So I think it's pretty important to evaluate pretty well what's happening with this patient that has an acute type of vertigo. And with the bilateral, the vestibulopathy, so we have to be aware of what happened with the patient. If the patient was at the intensive care unit, or if he's really old, or he has a bilateral Meniere's disease. So in that type, so according to the Barany Society criteria, we have to go into deeper on what's happening with the patient, and we have to utilize these type of tools, be it caloric testing or even though the video nystagmography. So that's what I have to say.
Perfect. No, definitely makes sense. All right. And of course, we cannot leave this discussion and go into the paper without addressing your favorite, mutual favorite, I think, persistent postural perceptual dizziness. So I have been able to conceptualize this as what I call a learned dizziness. The brain has made some changes based on its exposure to an event. So it could be a vestibular event, BPPV, a vestibulopathy, a vestibular migraine condition, or even a life event, as I understand. So something very stressful, typically, perhaps the death of a spouse, something like that. So something triggers the brain to, kind of get into this state where it's fairly constant symptom. It can be exacerbated by movement, but it's really at the root. If you want to talk about where does the pathology, the pathophysiology live, it's where the brain connections are not functioning in the typical way. So what would you like to add to that, Dr. Duval?
Well, triple PD right now is my favorite vestibular disorder. And why is a very interesting story, because when I was ending my ENT residency in Mexico, I had the opportunity to go to the Emory Center for Dizziness and Balance Disorders with Susan Herdman. And I was shocked to see a lot of patients that in Mexico I didn't have a clue what they are having. And of course, in that year, in 2006, there was not a triple PD yet a diagnosis. And I was very surprised. A lot of patients that were treated with antidepressants medications, and they changed their life. And in that time, my mentor, Dr. Tusa, told me, I call this anxiety-related dizziness, no? And for that time, let's say, oh, okay, it's interesting. There's a lot of patients. In the first years of my practice here in Mexico, I treated a lot of patients with that. But I was not really aware how big was the problem. And this is interesting because usually, for example, me as an ENT doctor, all my colleagues only see, or it's the majority of them only see a patient, for example, a peripheral patient, only as a problem in a sensor, in a motion sensor that you have in your inner ear, and that's all, and does not really care about what's happening with that patient after the lesion, or even only with the stress he was having, no? And I think many colleagues in this area, especially colleagues that haven't suffered themselves anxiety, usually put this group of patients in don't worry, it's a triple PD. It's anxiety, like it's something
just
that it's
don't
not
worry.
going to, that it's. I mean, he's not going to die if he has anxiety, and I don't know if I had the fortunate. I don't like to call that, but I had anxiety in like 10 years ago, and I feel myself what's a panic attack. And really, this is not a funny thing. This is a thing that can change your life, that can really distort the way you interact with other people, the way that you affects how do you work. This fear of only leave your house and make your normal things. And right now, of course, our main research topic for Melissa and me was this particular entity that we're going to talk later about. Not only triple PD, also trying to understand that if you have any kind of vertigo patient in front of you, okay, let's say a BPPV, a simple BPPV. I told my residents, you have seen in your life people that told you that, yeah, I sometimes, years ago, I lay on my bed and I feel a really hard vertigo, and well, it ended in 3 days, and that's okay. No. So not all the patients with BPPV goes to the doctor. Okay. What is the real reason that makes a patient to have BPPV and go to the office? It is not the BPPV. It's the quality of life that is affected by the diagnosis you have in front of you. So in triple PD is very, 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 very important, because usually the patient with triple PD has a very important quality of life, a loss of quality of life. And all our measures about the success of our treatments must be measured in terms of quality of life. Because in BPPV, for example, usually it's easy to see, okay, this patient comes to your office, you put in a Dix-Hall pike position, you see all the eyes jumping like he was like possessed, and you say to yourself, well, my outcome measure is that if I made an Epley maneuver, it is success if this patient is not really having more vertigo and more nystagmus. But in that kind of patients in triple PD, you are not going to see that. You are not going to see a physical sign or altered testing, vestibular testing. You are only seeing the deterioration of the quality of life. And all your treatments must be measured in terms of how can you improve the quality of life of your patients, because they're not going to be any physical sign of an easy way to measure if you're doing the things right.
Definitely. No, that makes total sense, and a very, very good point. So I think this is a great lead in to my last couple of background slides, and then we're going to go right into your slides. So I had done a little post about anxiety and vestibular issues and how they can be connected, because I've had a lot of patients and non-patients seem to struggle with this. So this is my understanding. The literature says that vestibular issues absolutely can contribute to anxiety. So it's not that every person who has a vestibular issue feels anxious about it. In fact, I've had a few patients that are like, nah, it's fine that I'm falling. Like they don't even, they're not worried at all. So it's not a one-to-one. For whatever reason, those folks are not concerned about getting hurt, I guess. But for the majority of folks, whether they have a history or propensity for anxiety or not, just having this kind of, especially if it's unpredictable, which many of these conditions can be, Meniere's migraine, vestibular migraine, BPPV, right? These can be unpredictable. We don't know when we're going to have an episode necessarily. So it makes sense that almost all persons with vestibular issues, regardless of specific diagnosis, experience some level of anxiety. And that certainly can, connect us from the body, right? So I don't know where I am. I call it the wait, where are we feeling? And this is scary to the brain. So there's definite loops that can occur, even if the person doesn't officially fit 3PD criteria at some point. That doesn't mean this looping is not happening. This kind of like not a true not sense of where I am in space, and this contributing to kind of, I've had patients say, look, I've never been an anxious person before. I don't understand it. Like now I'm feeling worried about a lot of things. And, it makes sense because again, as far as the brain and the brain processing and kind of telling us, from all this information, orienting us. And if it's not feeling secure about that, it makes total sense. And the science is there for this, right? And on the other hand, there is some research that says that having anxiety can increase the risk of developing certain vestibular conditions. So that's not great either. And the example that I have here on this slide is that patients with anxiety disorders have been found to be over 2 times more likely to develop BPPV. Now you might ask, well, why is this the case? Are they tossing and turning at night and moving their crystals? I don't know that they've gotten to that level, but the point is, it's kind of like, chicken and egg here. We've got, ways that vestibular issues can contribute to anxiety, ways that anxiety can contribute to vestibular issues. And so that is going to lead us to our slides for Dr. Belissa, and what can we do to assess quality of life for these patients, and what can we do to perhaps improve the quality of life for these patients. I hope we'll get that answer by the end here. So go.
So first of all, thank you very much. So this article, basically, we created this article because we were pretty concerned on what happened in our patients. So as PPD is one of the most common types of vertigo that we usually attend in our clinics in Mexico and here in Medellín, we really wanted to know what happens with the other vestibular disorders. So that's why we created this article. We just wrote it down. We had some helpers that were medical students and also from Mexico, from here, from Medellín. So our article is available. It's in the International Journal of Otolaryngology, Head and Neck Surgery. It was published last year. And so it was published in April. And our main question was, how many studies are known to include or describe the quality of life in patients with vestibular disorders? So we were pretty surprised of what we found doing this our search in Scopus, Cochrane, also PubMed, and also in BB Salud, that it's like the national database or the regional database of Latin America. So we were really surprised. We don't have any articles published in our region. Basically, most of the studies are from Brazil, some others from Turkey, some others from Germany, and some others from the US. So what it was really surprising is that benign paroxysmal positional vertigo was one of the most common disorders that also present this type of quality of life altering. So as you may see here, there were a bunch of patients. So there are some studies basically started on 2005, but we are still ongoing with this. So we are basically struggling with these people, struggling with our patients, and we don't know what we can do with the quality of life of the patients that have this type of vertigo that it really lasts some couple of minutes or some couple even for seconds, but really altered the quality of life of patients. So at least for this type of disorder, we have at least 12 articles, which is a bunch of articles that we can say. But when we were just going into the other types of vertigo, of vestibular disorders, there are some others that are non-classified vestibular disorders. So some of the healthcare providers just have these patients, but they don't know what type of vertigo they have. They only know that these people has an altered quality of life, that they can go working, that they can do some specific physical activities, or they can just can do some specific things that we were used to do. The other thing is the vestibular migraine. So with the vestibular migraine, we have like some studies, but they are just basically growing over the last years. One of the most important of these studies was from AC in 2022 in Turkey. So they were basically focused on what happened with these patients. And I think it's one of the most interesting studies that we have right now. And I do really just want to say to the people that they can just read it because it will be pretty interesting from ACT 2022. And also the unilateral vestibulopathy, we have some articles over the last 5 years, which is really impressive because now we are having like the sense, we are now basically trying to see what happens with our patients that have this type of acute symptoms, and also that what happens with them after vestibular rehabilitation. Because most of these people just go into vestibular rehabilitation, but after that, they continue with an altered quality of life, which is pretty interesting when we were doing this type of search. Meniere's disease is basically one of the most common types of vertigo, that it's episodic, that it's also pretty noisy. We have these patients that have also hearing loss, which also alters the rest of the clinical symptoms. And it's one of the clinical symptoms that is even more difficult to treat, and also the tinnitus that the patients have. So we have the vertigo and the other types of symptoms, but it really alters the quality of life, as you may see in the upcoming slides. And also we have the chronic vestibular dysfunction and the bilateral vestibulopathy, that they just say, okay, we have an altered quality of life, but it had lasted like for years. So we have patients that really have an altered quality of life, but most of them, they don't realize about it. Or they just believe that the type of life that they're having, it's really common with the vertigo that they have. And now with the postural persistent dizziness, there are only 2 studies. So we were really surprised of that, because this is really noisy. This is really disturbing. People can really, really get bad. And we have these only 2 type of studies. So this is, I think it's really interesting, but it's really concerning for the medical community, because we have patients, we have ill patients, the patients are not having a good life, and the patients have a disturbed, altered quality of life. So I think this is also a reflection for all of us, that we have to do something for them. And there are some scores. So even though that we know that the patients may be pretty sick, some of these questionnaires could be also done on the clinical consultation. So which score systems are utilized to measure quality of life in vestibular disorders? So what we have seen is that some of these type of questionnaires could be used, even though that we are not a psychiatrist or we are not psychologists. But for example, in our clinics in Mexico and here in Medellín, we use, for example, the European Quality of Life 5 dimensions, or the EQ 5D, which is really easy to do it. We have it incorporated in our clinical records. So it's pretty easy, because you can just ask about anxiety, depression, also talk about how are the people doing the physical activities, if they have any impairment to do, for example, their work, or for example, their activities or leisure. So it's really interesting, and it's you can just take it in 1 minute.
Wow,
you have a
awesome.
really, really good, that's really good. And we have done some studies with this, but there's also some other scales. So we have, for example, the anxiety scales that have been used basically in BPPV. We have also the Beck Depression Index that it's also used in vestibular migraine, in PPPD, in Meniere's disease. And we have also some cognitive failure questionnaire that it's the CFQ, that it's basically only described on Meniere's disease and vestibular migraine. And also we have, but this, I think the physiotherapists may know the PADL, that it's even more common for you than for us guys, and the ABC. So these are some tools that we can use during the clinical consultation in our rooms with the patients. It only lasts for 1 to 2 minutes, so it's pretty easy to do it. And we have also the short form 36, the health survey. It also includes like some items about quality of life, but also about movement, and also one of the most common questionnaires that it's not basically focused on quality of life, but really gave us many information, is the dizziness handicap inventory. So with the dizziness handicap inventory, and also, for example, the EQ5D, we have developed some studies. We are going to present one of these in the upcoming Barany Society meeting. So there's a bunch of things that we can do, and we can just evaluate the patients.
And I think for clinicians out there, I've had some of them say, oh, well, what do I do for this 3PD patient? Their balance is pretty good. So as a physical therapist in particular, we're pretty tied to doing outcome measures to try to show change, which is understandable, right? And it makes sense that you would want to try to see progress, or kind of be able to demonstrate that the patient is, benefiting from therapy, or that do we need to change something? What are we kind of progressing on? What are we still kind of stuck on? So I think it's really a great point to think about, which of these might be a good idea for more clinicians to consider if they have kind of an early sense as they're talking to the patient. Maybe you give it to them at the end of the session or something if they have time. It's not always clear at the beginning of the session. It's just easy to give everybody a DHI. I think that's the most common questionnaire, but there are patients who they're not always that dizzy. I mean, I certainly have had patients where it's more kind of I feel off, and they don't really connect with the word dizzy. And so I think it's nice to think about quality of life, because that's about how is this affecting me, and this is really a nice way to pull out some direct, specific functional goals, which we also care about very much, at least as physical therapists, and I think doctors care about this too, so that the person can get back to walking their dog around the block, so the person can be able to, reach down into the crib and pick up their child safely, or feel like they're not going to fall over when they get up to the top, with the kid in their arms. So these are the things that have been brought to me by my patients that I think about. And I think that being able to use, some questionnaires to kind of formally try to get some rating, so that we're hopeful that for some patients, at least as we do therapy, we can have them rate, oh yeah, this is not bothering me as much, or, even if it's not 0 or not perfect, whatever, that's not always feasible. Certainly with vestibular migraine in particular, I find, depending on, patients' triggers, they're not necessarily going to be symptom-free. But we have a lot of conversation and education about expectations, and I think most clinicians are hopefully aware that that's an important part of management. Not that we don't want to be symptom-free, but, just kind of, what can I do to maximize my abilities, or to feel as good as I can, and know that some days might be rough because one of my triggers is weather changes and I can't change the weather. So, how are we going to manage or, minimize symptoms at those times, and overall have a functional life. So.
No, and as you said, it's very important in this triple PD patient, very important to talk the same language that the patient is trying to speak with us. Because, for example, if we are treating a patient with vestibulopathy, usually we can have a BHIT result, maybe with a lowered gain in the testings, and usually we focus only on that number, but not what that real number really means in the everyday life of the patient. In fact, there was a very interesting paper written by Adolfo Bronstein that compares in patients with vestibular neuritis, trying to correlation it if the improvement in BHIT or in calorics does really correlation it with the patient happiness or the result, and was not really a correlation. They have patients with lesions with very low gains in the BHIT that are asymptomatics with a dizziness handicap inventory of 0, and patients with all the testings normal and with the dizziness handicap inventory in 75, for example. And it's interesting to say to all the healthcare professionals, what's the difference between the scales, or what are the things? Because I know, for example, DHI is the most used scale to assess the perceived handicap for a dizziness, for a vestibular problem. But not really have, it is not the same to have a handicap than to have a alteration in your quality of life. For example, I can be handicapped for dancing, but that doesn't mean that if after rehabilitation, if I can dance after that, does really improve my quality of life. Maybe I really never dance, for example.
Yeah.
For me, it is not important. But it's important in the scale that Melissa talked, the EQ 5D, you ask 5 questions to the patient about the mobility of the patient, how altered is by the, no matter the diagnosis you have, how this symptom altered your mobility. You ask about how this sickness alters your self-care, how this sickness you have altered your usual activities. I mean, and this is the question. This is your usual activities, not the one that says in the DHI, for example, no? And how this sickness has gives you discomfort or pain. I mean, dizziness does not really hurt, but it causes a lot of discomfort. And how is the self-perception of anxiety and depression? And that really hits in how a patient feels in the everyday settings. So maybe our focus in this series of papers is trying to put the awareness of the health professionals to see the patient not only if he can stand in one leg or for closing her eyes for 5 seconds. No. Try to put that in the everyday activities in the patient.
Sure. Not that we shouldn't measure balance and that's for, reducing risk of falls, but I totally agree that quality of life is very important. So what else do you have for us, Dr. Melissa?
So I just want to ask my colleague, and I think he will be really happy to answer this. Which aspects of quality of life can be impacted by different vestibular disorders?
Yeah, and this is important because we have said that vertigo and dizziness are not diagnoses per se. There are symptoms, there are sensations that are felt by the patient. And they have a different etiologies, different causes, central, peripheral, whatever, but they have, all the vestibular diagnoses have things in common. Mostly all of them alters balance and motility. Most of them alters the emotional well-being of the patients and the social functioning. And no matter if you have crystals moving in your semicircular canals or you have a very big stroke in your cerebellum, they share these things. They share the fear of falling. They alter the cognitive functions. For example, it is very common to hear the patient says that as long as the day are passing, the hours are passing, they feel more and more dizzy, because for the brain, it's like trying to talk in not your mother language all the day. O sea, your brain for example, why it's so difficult for the patient to explain what they are feeling, for example, because most of the patients have already in the past feel pain or nausea or diarrhea or whatever. But when you have a patient for the first time with dizziness or vertigo, usually the normal people are not aware that we have a vestibular system until it fails. And that for the brain, it's a very, very complicated task to trying to solve, because almost all the wirings in your vision, in your vestibular, peripheral vestibular, is like hardwired. They are like you don't need to think.
It's an automatic pilot.
Yeah,
I always like to say the automatic pilot is broken, and so your brain has to work so much harder. Like being dropped off.
A lot of CPU,
yeah,
an extra CPU to trying to figure out what's happening. No,
yeah.
So you are not well. Your work, your daily activities are going to be altered. You are not going to be the same guy when you are feeling dizzy or when you are having vertigo.
So we will just compare what happens in different disorders. So the first, in different vestibular disorders, which items of in quality of life are affected or altered. So we will start with Jorge with one of his favorite topics. So that's benign paroxysmal positional vertigo.
I think all of the healthcare professionals, we got in love with the BPPV. The first time you see a patient that you are putting in a Dix-Hallpike position and see the eyes moving in a way that you have never seen, like torsional movement of the eyes is very, very impressive. And also it's very impressive to see with only a physical maneuver to get rid of that in most of the cases. And it is very interesting how the different patients interpret this positional vertigo in a very different ways. I am sure that all the people that are hearing this, they had patients, for example, that have a very bad BPPV, as in with very nasty movements, and the patient is like, cool, I am okay. Yes, I am feeling that I'm turning, but I'm cool. And also, all of us have found patients with a little bit BPPV and screaming like they are like tossing the limbs apart from the patient. It is very interesting how the brain interprets in a different way the same sensation. For example, in our study, we found that the patient with BPPV, some of them, not all of them, but has increased anxiety levels and depression during episodes. It is very common, for example, for a patient that has her second BPPV episode. Now, we know that almost 50% of the patients with BPPV are going to repeat sometimes. And in the second episode, they feel that they are never are going to be all right again. I said, doctor, I'm going to fight with this for the rest of my life. And you say, whoa, take a break. I mean, this is like the same like a cavity in your teeth. I mean, it hurts like hell. And of course, you go to the dentist and they put some things that is often painful and you're okay. And that doesn't mean that in the future, you can have another cavity in your teeth. I mean, for that event, that's over. And that's the same in BPPV. When you treat a patient with a maneuver, you are already curing the patient. They can have another one in years forthcoming, but the patient needs to be aware that it is not something that it's going to I know, that stress about this is going to change my life forever, and it's okay, take a break for that. When they are feeling with fear, of course, they diminish the time for walking and the fear of falling increases. And the fear of falling is a very interesting thing, and you, the physical therapists, know more than us about that. A patient that is having fear of fall, it is more easily that they are going to fall because they alter the way they are walking, the distance between the feet, the length of the strides. I mean, if you are fearing about to fall, you are more likely to have a fall. So it's very important to address that. Of course, you have work limitations due to the emotional and symptoms. You are having a time using more CPU, as we talked before. And this is very common, and I'm sure that everyone that has treated a BPPV has found this thing. No matter if you have a patient that you can lay in your office in the disc Hall pike maneuver and says, look, there is no more vertigo. You can put yourself in bad position, wherever you want. And the patient comes to their homes and they are like putting 3 pillows in the bed. And I don't want to roll in my bed just because I don't want. So it is very important to address the patient that once they don't have the BPPV, they can have their normal life, because some patients are going to alter the everyday movements, no matter if they are not right now having the BPPV. Okay, and again, they can alter the mobility and leisure activities. In fact, leisure activities are one of the most affected in no matter what. In triple PD is more evident. Almost all the patients that feel dizzy, the first things that they alter is their things that they have leisure, their social activities.
The things that bring them joy.
Mm-hmm. That's the reason for living. And this is also, the second part is very important, because at least here in our countries, it's a very not so correct explanation about the dizziness and vertigo. And it's unusual and easy explanation to say, oh, your dizziness is caused because you have contracted muscles in your neck. And that's why, because you're feeling dizzy. I mean, it is almost impossible for a neck contraction to put you in a vertigo symptoms. It is more likely that your neck pain is secondary to your dizziness, because almost all the diagnosis in the vestibular usually get worse when you move your head. So your body is like auto-protecting you, trying to put like, please don't move.
Frankenstein mode. It's like locked
so
in
it's important
robot, right? Like
exactly.
Something like that, right?
Because not all the patients that have neck pain are feeling dizzy. Okay.
So I just want to talk about vestibular migraine. So there's an increased cognitive impairment. It really impacts work and mobility. Motion and mobility impairment exacerbates cognitive impairment in daily activities. So patients with vestibular migraine really have a very bad time. So sometimes they don't have any tolerance to, for example, stimuli, even some of the stimuli that can be visual or can be sounds or can even be odors or smells. So sometimes they really have a very bad time, and we can see it basically in women. So that's, even though it's some related to some estrogenic changes that may happen also in women. Regarding Meniere's disease, so there's an increased disability during physical activities. So that's one of the most common findings that we found and we described in our study. So, which is really impressive because these are basically episodic syndromes, vestibular syndromes. So there's also a quality of life that it's pretty altered, but it's even more easy to see what happens over the time. Because when you have a BPPV, it's really short, but it really happens once. But with this, we can have patients with months, even years, that they have this type of alteration. So there's also work-related communication disabilities. The patients are not pretty well or don't feel pretty well when they have to communicate ideas or when they have to do, for example, executive functions. So they really feel bad and they don't feel that their development or their improvement at their work, their performance at their work are really good. And the hearing loss also often leads to anxiety and communication issues. So it really happens. It's not only the hearing loss, it's also the tinnitus, the ringing ear, and the vertigo. So
and my understanding is that hearing loss also increases that social isolation. Is that correct?
Yes.
Yeah.
That's totally correct. So that's what really happens. So Jorge, talk about this unilateral vestibulopathy. That is also one of his favorite topics.
Yes. Well, here with a unilateral vestibulopathy, you have a patient with a motion sensor that is not working very well. Of course, in only thinking about that, you can infer that a patient with vestibulopathy, unilateral vestibulopathy, will only have symptoms where they want to move their head. But we need to separate in two parts these patients. In the first part, when you have this acute vertigo, of course, as Melissa said, it's very important to make a HINTS protocol to differentiate between the patient with a potential stroke in the posterior fossa compared with only a viral inflammation of the cable that brings the information from the movement sensor in the inner ear to the brainstem. So this is the first part. The important part is like to feel like having a chest pain. Not all the chest pains are going to be a heart infarct, but for the probability that for maybe 1 of 10 patients that have pain in the chest, we need to test all of them, trying to find this potentially fatal patient that have this diagnosis. So in the first part, of course, in the first days of acute vestibulopathy unilateral, there's going to be a lot of vertigo, a lot of nausea, impossibility to walk. It's a very symptomatic part of the disease. And there's, of course, panic. Most of the patients thinks about something very, very bad happened in their brains. So it's understandable that if they're feeling this for the first time, it is very, very fearful situation. The next.
So the next one, it's bilateral vestibulopathy. So it is really described and pretty well described that that's an increased economic impact and more loss of work hours. So we have the patients that are pretty elderly, but we have young patients that have this BVL, which is really, really not only disturbing for a patient, it really impacts on the quality of life, on the performance of work, and also it impacts on the social communication of the patients that are still being working or still doing physical activities, leisure activities. So the bilateral vestibulopathy really, really impacts life. And the patients arrive to our consultations and usually says, I can do this, or I prefer to do not this because I will feel fearful of just not only falling. I feel like if I'm drunk. So sometimes they just really be aware of that. And there are some evitative behaviors and the patients really get with social isolation.
Yeah,
So
these patients are the most imbalanced
mm-hmm.
overall on average in my experience. They fall, even if they're young, they can fall. Whereas the unilaterals can kind of, I feel like, compensate a little more because they at least have one sensor working. And this group is really, really afraid on an understandable level of the dark. So any dark or dim environment, what if the power goes out? These are the kinds of things that we have to talk about strategy for. So from a therapy side, we know in the literature, on average, these folks are going to probably need like 8 to 12 weeks of therapy at least. Like we're going to have a longer, time with them. And I totally can see how this would be very life altering for quality of life, work, etc.
No, and I think, well, sometimes our patients just arrive to the consultation with wheelchairs. Also, they have to be with people. They have to be with some family just to be supportive, or just for doing social activities, or just for going to the supermarket, or just going for the physician. So sometimes bilateral vestibulopathy, I think the role of the physical therapist or audiologist that makes a vestibular rehabilitation is critical, because without you guys, we can have a good rehabilitation of our patients. And also the support of the cognitive behavioral therapy, it's also critical, because you can just improve the dizziness of the patient and also the severity of the vertigo. But if you don't improve the other things, the other items of this quality of life, you're not doing anything. So for us, it's pretty important, and I think Jorge agrees with that, that we do really need the mental healthcare providers that are dedicated to this area. And we do really need the support, not only in the bilateral vestibulopathy, I think for all the vestibular disorders as well. And finally, this one,
the triple PD.
Persistent dizziness years.
Well, we have talked a lot of minutes in this session about that. Of course, when you have triple PD, there's increased physical, emotional, and functional impairments in combination with big levels of depression, anxiety, and also stress. And as Melissa told, it is very important in the triple PD patient because right now we have 3 treatments or 3 weapons to try to fight this. The first one are the medications, antidepressants, inhibitors of the serotonin reuptake, medications that increase your levels of serotonin. We can use for the patients benzodiazepines. I mean, most of them are treatments for anxiety mainly. The other weapon we have is, of course, vestibular rehabilitation, particularly habituation exercises, trying to put the patient in a systematic way to be gradually exposing the patient to the things, the movements, the lights, the that makes the patient feel very, very ill, and also the cognitive behavioral therapy. The problem here is that there is no one professional health care provider that can give the three of them. There is no. I mean, for a physician, I can learn vestibular rehabilitation. For an audiologist can also learn, for example, how to give a little bit of therapy, but there are not in this world a person that can give the patient medications and also vestibular rehabilitation and also cognitive behavioral therapy.
Yeah.
So
yeah.
it is very important to work in a team that takes the patient with triple PD, and there are a lot of different patients with triple PD. I mean, the diagnosis does not end only telling the patient you have triple PD, because if the patient have, for example, anxiety and depression, of course, we can have medication as a very quick way to put the patients okay, but it's not going to change anything. You are only giving the patients temporary relief medication, and that's all, for example. And if you only give the patient vestibular rehabilitation, maybe in the next, if the anxiety grows, your vestibular rehabilitation is not going to work. Or maybe if you don't control the anxiety, it is very hard for the physical therapy to try to work and try to fight this fear the patient have to certain elements. And you need to take the patient as a whole. In fact, we have a paper written the last year, if I remember okay, that we put our triple PD patients with a lot of different questions about how they feel in terms of anxiety, depression, social phobia, in terms of feeling the sensation of vertigo, the dizziness. And we asked the professional vestibular people in Latin America, the healthcare in the vestibular world, about how they think the different weapons we have, the vestibular rehabilitation, the behavioral cognitive therapy, and the medication, what they feel they improve in that patients. And they improve different things. So we need to have these triple PD patients in different subtypes, and trying to offer, maybe it is not possible to offer the patient all the three weapons, but trying to offer the treatment that can resolve most of their complaints in terms of what they are feeling.
Yeah, and I think vestibular rehab and also the doctors who might prescribe SSRIs or something like that, they sometimes need to build a relationship, in my experience, with a patient, because in my experience, and maybe it depends regionally, I'm not sure, patients are not always open to the cognitive behavioral aspect, that they, maybe feel like that's a sign of something that they should be able to figure out on their own, and why do I need this, or can the rehab fix me? So I try to introduce it, kind of like the timing is right. So I have built a rapport first. We do a few sessions of vestibular rehab, and then I usually gently then say, you know what, a lot of the research says that, these three elements are all important, just as you explained. And, I think that if we really want to be successful, this would be something to consider. And I'm lucky enough that I have someone in my area who actually have had vestibular symptoms and issues themselves. And so I refer to her a lot, because I'm like, this person gets it. And so, that often can make the patient more comfortable. So it's important to try to find providers as best you can. And if they're not familiar, but you feel like you can build a rapport with them and maybe educate them a little bit, that might help them to apply their training with kind of the vestibular awareness, we'll call it.
So, and lastly, so we want just to, first of all, I would like to thank you, Helena, for inviting us to this wonderful journal club. For us, it's an honor. We are really glad to share this in another language. We have our social media of La Academia del Vertigo, and you can just follow us as well. You can just follow me with MC Bustamante, and also Jorge with Dr. Jorge Madrigal, and also the Academy of Vertigo. And we are really, really happy just to share with this. I hope that this information that we have given you today will be helpful for our colleagues, not only in Latin America, also in the US. And we are really looking forward to meet you all at the Barany Society this year in Uppsala.
Awesome. No, absolutely. And for me, I thank you all. I will give a plug for your Academy del Vertigo. I think anyone who is Spanish speaking would greatly benefit from taking any education from you all. So I've listed some upcoming courses here. Some are past, but most are yet upcoming, including the International Vestibular Rehabilitation course in Mexico City, which I believe you still have planned for July, as well as some other courses later in the fall, or I guess that's your spring. Anyway, so I will conclude by saying that I have some resources here on this last slide. For those who, kind of need more internet-based resources, maybe you're international and you are looking for some folks to follow. In addition to following Dr. Bustamante and Dr. Duvall, I do recommend following some of these folks who have some excellent resources for patients and clinicians alike, as we're trying to help these patients with their quality of life and emotional support and things that are so necessary. So I'll just conclude by saying thank you both for being so kind as to give your time, your knowledge, your expertise. You're both fantastic, and we're very lucky to have you on Journal Club today. So we look forward to seeing everyone next time at our next Journal Club, and everyone take care.
Thank you.
Thank you.
All right. Awesome.